Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Pete, I'm doing outstanding. How are you today?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of our guests. Okay, today, so we have a special episode for you. We've invited Dr. Xavier Duralde on the podcast. Dr. Duralde is just completing his presidency of the American Shoulder and Elbow Surgeons Society. Dr. Duralde is well known to many members of our society and many of our listeners. For those of us who don't know him, he completed his training at Columbia before entering the Air Force. And then he went on to Peachtree Orthopedics in Atlanta, where he's been for many years, serving for many years as the team physician for the Atlanta Braves. Dr. Duralde, welcome to the podcast.
Thank you. Glad to be here.
Dr. Duralde, tell us, how did you first become interested in shoulder surgery?
It's funny when I think in everybody's career early on, you're interested in medicine, you're interested in science, and then you start to focus as time goes on. And you hear people say things happen by chance, and so I was at Columbia for medical school and really enjoyed it. Thought it was a great place, and then I stayed there for orthopedic training. And I worked under Dr. Charles Neer, who was really the premier shoulder surgeon in the world at that time. And we would see people come from all over the world to train under him, and I realized the incredible opportunity I had at that point to do something like shoulder, and that it was really a unique opportunity for me. And so when I was trying to decide whether that made sense or not, one of the things that some of the things I thought about was, well, how challenging is it, and how much room is there for advancement and for research and that sort of thing in the field. And I realized that most people around the country felt like the shoulder was sort of a black box. It was a difficult joint to understand. It was a difficult joint to operate on because of all the adjacent neurovascular structures. And so that if I were to learn how to take care of shoulders and focus my practice on that, that most likely people would be very happy to refer those patients to me because they were so complicated. So, it's the old story of early on, it's about your interests, and then later on, as you get further in your career, it's about your mentors. And so really Dr. Neer was the person that sparked that interest in me.
And you haven't looked back since. Tell
No.
us, tell us a little bit about your time in the military. Tell us about that experience, how it shaped your practice, your approach to patients. We see a lot of surgeons, especially shoulder and sports surgeons, who have military background, and I'm sure many of them are listening to this right here, right now. So tell us a little bit about that.
Well, I decided early on that I wanted to spend some time in the military at some point in my career. Even when I was in college, I said, I really wanted to find a way to make that work. And then the health profession scholarship program was just perfect. When I found out about that, I said, I'm definitely doing it, because I thought it'd be a very interesting way to start my career, and didn't know how long I would want to stay in and what the opportunities would be. So it was sort of bittersweet in some ways, because I wanted to do the fellowship in shoulders with Dr. Neer as soon as I finished my residency, and but I was deferred by the Air Force through the end of my residency, so I applied for one more year of deferral before going into active duty to be able to do the shoulder fellowship, and the Air Force said no, they needed people now. And things were starting to heat up in Europe. I mean, the Cold War was still going strong. This was 1988, and we had just been bombing Gaddafi, and things were heating up in the Middle East. And so the military wanted everybody coming in, and so I turned down the fellowship, and I came in, and I really wanted to go overseas. And so I spoke to the people who made the assignments, and basically, when you're coming out of residency, you pick last in terms of your position. But there's a period of time in which the overseas assignments are being made, and everyone who wants to volunteer has already done so, and there's some spots left over in overseas that nobody wants. And so I told person making assignments, call me when that time comes up and I'll volunteer for one of them. So you'll have, one less person that you have to assign that doesn't want to go there. And so I wound up taking the spot in England, in Oxford, England. It was a NATO base, and it was very interesting. We were F-111s, fighter bombers, and electronic jammer planes. And when we got over there, you would have thought that World War II ended 10 years before. I mean, it was unbelievable. We were in the field once a month in full chem gear, and we were ready for the Russians to come over the wall anytime. And the interesting thing was that was in the days of Reagan, and Reagan had the Russians so scared that they thought we were going to attack them any minute. So they were on full alert. We were on full alert, and it was sort of crazy. And it stayed that way for the first couple of years until the Berlin Wall went down and the Soviet Union started to fall apart. We thought, oh, good, now we can kind of cruise. And then all of a sudden, Kuwait gets invaded by Iraq, and so Saddam Hussein suddenly gets rid of all of our downtime, and so suddenly we went on alert again for Desert Storm, prepared for the war, opened up all the contingency hospitals, and it was a pretty interesting learning experience in terms of all that. The practice itself overseas, the practice is a sports medicine practice because retirees aren't over there, so you're not dealing with that population. Anybody who has any significant medical problems is not allowed to go over. And so, you're seeing guys that are running around out in the field doing things and tearing their ACLs and hurting their shoulders and fracturing their ankles. And so it's a sports medicine practice. And so I learned a lot doing that. I was the only orthopedic surgeon at my base. So I came straight out of residency training, no fellowship. You sort of feel like you don't know anything and you're sort of thrown into the fire. And so like anybody, those first 2 years were a real, steep learning curve. But, it gave me a lot of confidence, and it also allowed me to learn what I didn't know. And so I'd be struggling through these shoulder operations and having trouble and trying to figure out what I was doing wrong. So actually, when I went back to do my fellowship, I was a much keener observer. And when we got to those critical steps where I was struggling, it was like, the light bulb would go off, like, oh, that's how you do it. So I think it was a much better learning experience when I got back. I mean, the other aspect about the military is all the leadership, so everybody in the military is young, so you take leadership positions earlier in your career than you would normally in a civilian practice. And so, I got over there and they said, oh, you're the chief of orthopedics, and I said, yeah, chief and Indian, because I was the only guy there. But within 2 years, they made me chief of surgery. And so I had 7, other surgeons under my command, the general surgery, OBGYN, those sort of types. And then I also shortly after that became the assistant chief of hospital services, which we would nickname holiday commander, because when the holidays came up, the hospital commander and the chief of hospital service would both go on vacation, and you were left stuck there at the hospital. But it was great to learn how to run a hospital and how to run, the staff. So I think I learned a lot in leadership when I was in the military for that's really helped me since I got out.
So I just want to make sure, I understand. So you did a Columbia residency, then you went to the military, and then after experience, you went back to become a Columbia Fellow.
Yes. Yeah, and so that's kind of it. So in terms of your education, it's probably ideal because you're out there operating on your own for 4 years, and you really you figure out what you don't know, and then when you go back to fellowship, you learn so much better because you're not worried about having the knife in your hands because you've been operating for independently for 4 years. And so it was a fantastic year for learning. I mean, it was just, and I was much more mature, obviously too. I was already a member of the academy. I was board certified. And it made it a lot easier to kind of, move around the operating room, and I could focus on the things I didn't know, the reason I was there. And so, and, then leading, directing residents and things like that was a lot easier because I've been doing it leadership positions for so long. Financially, it was a nightmare because I had 4 children by that point. And so I came back to and Columbia is not in a good neighborhood. I mean, it's better now than it used to be, but it's the northern part of Harlem. And so I decided I was going to rent a house in New Jersey for my family to live in while I was a fellow, and my rent was my entire salary. And so I had to call my brother and say, "Hey, would you lend me some money to make it through this year?" And he's kind enough to do that, and I had to pay him back the next year. But yeah, so it was what my wife and I called our year of austerity, but it was definitely worth it. We kept saying, think ahead, look forward, focus on the future, because I knew at that point that the skills that I was going to get that year as a shoulder fellow were going to, pay back in multiples, because, I wound up coming down to Atlanta. And when I came down to interview here in 1992 for a job, people in Atlanta did not know what a shoulder specialist was. There was no one here who was a shoulder specialist. They had a couple of sport guys that liked shoulder, a couple of hand guys that liked shoulder, but nobody's doing complex shoulders. And even the university, when I interviewed with them, they said to me, "Well, you can either be an arthroplasty surgeon or a sports medicine surgeon. Those are the only two divisions we have here. We don't have shoulder." And so I realized that there's a lot of opportunity, because that kind of mentality and that kind of level of training leads to a lot of undertreatment in a community. And when I got here, I saw patients who other doctors had given up on, and they were literally routine cases that we would do 3 to 4 times a week at Columbia. And so it was fertile ground to develop a shoulder practice. And, a couple of years later, the university called me back and said, "Can our residents rotate with you?" And because they realized they needed that. And, subsequently they've brought in shoulder. They offered me the job, and I did not want to go to the university at that point. They brought in shoulder people. So now they've developed that. But, 30 years ago, nobody in Atlanta really, knew what that was. So it was sort of trailblazing.
Now, when you were back at Columbia at a really storied time, it sounds like Neer was there, Bigliani was there. I'm sure were you there while Fleta was also still there?
Yes. So my relationship with Flato is interesting, because he was my senior resident. He was 2 years ahead of me in residency program. And so at Columbia, this was the old fashioned program. It was 2 years of general surgery and 3 years of orthopedics. And so when you came in as a third year resident, you were on the bottom of the rung of orthopedics. And then the fifth year guys ran the services. And then two people in that year were selected as chief residents. And so Dr. Flato was one of those two people. And so when you're chief resident, you make the schedule, and you schedule every single person on in the program every day. And so you have a lot of control. And so he was the person that controlled all of us when I was a junior resident, And so of course you grow to hate people like that, but but he was a good guy, he was very particular, as he is now. And so you feared him, when you saw him come down the hall, he'd reach to his pocket to see where you were supposed to be at that moment, But so then I left for 4 years and I came back, and then now he was a professor, So then he was my professor when I went back for the fellowship. Dr. Bigliani was in charge, and then Dr. Flato was the his assistant, and those two guys were great. I mean, Dr. Neer is a very interesting person. I'm sure you've heard a lot of stories about him. He was not a man of many words. You would ask him a question, and he'd kind of turn and walk away, and you weren't quite sure if you heard your question or not. And then the next day, he would come up to you, and he'd basically recite chapter 4 out of his book in answering your question. I mean, it was unbelievable. And with Dr. Neer, you had to be comfortable with silence, because you get a long period of time where nobody would say anything. You just have to wait for him to say the next thing. And then Dr. Bigliani and Flato were very different from each other and from Dr. Neer. So Dr. Bigliani had a million things going on at any time. And so we used to joke when you're a fellow that you could only ask Dr. Bigliani one question each day. And so you had to really pick your question very carefully, because that was it, because he didn't have time for a second question. And so you're working on a research project. You wanted to know what critical piece of information you needed from him to help you move that research project forward, and if you asked him some other question, that was it. You had to wait another day. And so the other thing about Dr. Biliani was that he was a masterful surgeon, and you'd watch him operate, and he'd do things during surgery, and you'd say, Louis, why did you do that? And he'd go, she needed it, and then he'd have a hard time explaining. It was always the right thing to do, but he had a hard time explaining why he'd done that. And so Evan was the opposite, so you would say, you'd be operating with him, and you go, Evan, why'd you do that? He'd turn to the scrub nurse and go, marking pen. And then next thing you know, there'll be all these physics calculations and formulas written on the drapes, and, explaining, all the minute detail of why he did a certain thing. And the nurses hated it because, delayed surgery. But, they were sort of the yin and yang of each other, because, they're both brilliant, but one explained ad nauseum and the other one had trouble explaining it at all.
Do you have any other stories about Nir? We haven't had a lot of people tell Nir stories about Nir. And he's obviously such an important person in our field.
Yeah. There's a million stories about Dr. Nir. He was a, it's very interesting. He was at Columbia in the 40s, and his career was interrupted by World War II, and he was active duty in the Army. And then he came back, and he was really interested in trauma. And so his whole development of the prosthesis came about for 4-part proximal humerus fractures that had terrible results. They didn't have a good solution for them. And that's how he designed the prosthesis. And the original prosthesis, had a triangular stem, had an unusual shaped head to accommodate the rotator cuff, and he had no glenoid. And one of the reasons he had no glenoid is because he didn't know about methyl methacrylate. And so, as time passed, he sort of realized he could start using this prosthesis for arthritis. And then he realized he needed to come up with a glenoid. And then another professor, who's one of the Charnley's first fellows, came to Columbia, Nas Eftekar, and the story goes that he taught Nir how to use methyl methacrylate, and that really helped sort of in the development of the glenoid and that sort of thing. So, but Nir was extremely thoughtful, very quiet person, and he'd kind of look right through you. He was, it was very intimidating, So when we would present in grand rounds, the theater we had was the old time theaters you see like in the old paintings, where it was very steep, and you're down in the pit and everybody's looking at you. Well, Dr. Nir was sitting in the front row, and he would stare at you. And if you said anything that you couldn't back up, you knew you were dead. Because he would call you on it. And so you really had to be prepared when you presented to him, because you knew that, there was no BS. And I think, that really kind of helped you prepare for surgery and for patient care, because you knew you really had to know what you were doing before you could make recommendations. If he didn't like somebody, that was it. They were toast. So if you ever asked to say, well, I can't make it to surgery because I have something else to do, you were in trouble, because he would kind of write you off. But for some reason, he always liked me. I always liked him. We got along great. And, so I always had a very, very good experience with him. He was my third year preceptor in medical school. And so it's kind of a funny story. I was I was rotated on orthopedics, and at that point, I was still thinking about general surgery. And he asked me, "What do you want to do?" And I said, "I think I want to be a general surgeon." And he said, "Okay." And so then later on, I had this conversation with my father, who said, "Don't go into general surgery." He was a general surgeon, and so he said, "You really need to rethink orthopedics, because I think that's a good field for you." And so I signed up for a sub internship in orthopedics, and I really thought about it more. And I thought, my dad's right. I should go into orthopedics. Really, it's an interesting field. And And so then I called Dr. Neer's office and I said, I was going to apply. So I was going to apply for orthopedics. And the Columbia tradition is that you ask your third year preceptor to write a letter for you. And so then I asked another attending and said, well, you have to ask your third year preceptor. That's the policy at Columbia. And so I called Dr. Neer's office and he said, yeah, I'd be happy to write you a letter. So he wrote me a letter. And at this point, I had no idea who Dr. Neer was. All I knew was he was my preceptor in third year and he's a shoulder guy. And so then I start going for my interviews for orthopedic residency. And it soon becomes apparent that Dr. Neer is somebody very important. And so the people tell me, Dr. Neer? And I'm like, yeah. And they go, well, what's he like? And they're asking all these questions about Dr. Neer. And I'm like, oh my God. So, you don't really get to look at your letters. And so when I interviewed at George Washington, they had a thing where you had like 8 interviews and you would carry your portfolio between rooms. And so when one room there was a delay, so I opened mine and I read Dr. Neer's letter and he wrote me this fantastic letter of recommendation, but I still can't get over. I mean, because literally it's a 2-week rotation. And, I guess, I made a good impression on him because he wrote me this incredible letter. And the last sentence of the letter was, I would like to see him in our residency program. And so when I went to interview at Columbia, they told me, look, Dr. Neer wants you, you're in already. And that was it. So he was, very powerful person, very, carried a lot of weight and certainly, launched me on my career.
It's honestly incredible. I mean, these stories, I'm just thinking, what would it be like, if Pete and I were med students at that time, or what would it be like if Dr. Neer was practicing now and there were med students, just with the culture of medicine and medical education today. And your experiences are just incredibly fascinating, and I feel like we could go on for hours about different stories. But for the sake of the podcast, we should ask some additional questions about you and your career. So I know, as a sports surgeon, I'm incredibly passionate about team coverage, and you've had an amazing experience as a Major League Baseball team physician, which is not the standard for shoulder surgeons. While shoulder surgeons, of course, are intimately involved in team care for all different types of athletes and sport teams, oftentimes it's more of a traditional sports trained surgeon who takes on that role. So tell us a little bit about that, and for our shoulder and elbow listeners, how might they be able to get involved in such opportunities like this?
So I was very fortunate. I joined Peter Orthopedics, and our one of our sports medicine doctors was a team physician for the Braves, and our practice had taken care of the Braves for many years. And so, I had done an adult reconstructive shoulder fellowship, and so I felt very confident with arthroplasty, revision surgery, rotator cuffs, fractures, that sort of thing, and I had sort of a passing knowledge of sports and of sports injuries. And so I was ill prepared to take care of the Braves. And so I was interested, and I always liked to teach. And so from the moment I got to Atlanta, I started teaching everywhere I could. I became adjunct faculty at Emory, and I gave grand rounds a couple of times, and I would speak at our regional conferences and our state conferences, things like that. And so I always really felt strongly about the power of education. And so I convinced my partner to run a course on a youth safety in baseball, and this was like 1996 or so. And Dr. Andrews at that time was already pushing this as a big topic, and the explosion of UCL tears and all that sort of stuff was already happening. And so I convinced our 2 main hospitals in Atlanta to sponsor this and the Braves to run it. And then we invited all the little league coaches in the area. And then we had like a couple of the pitchers, John Smoltz and one of our relievers. And we had our scouts. We had the different personnel talking about what they look for and that sort of thing. And then, and then tried to emphasize, safety. And so it was a very well received course. I mean, the Braves liked it because it's community service and it's all about, health and welfare and that sort of thing. And the hospital loved it because of the advertising and stuff. And the Little League coaches loved it because they got to see all the Braves stuff. So it was really very successful. So a year later, or about a year later, there was an opening in the Braves. One of the physicians retired, and so out of the blue, they called me and said, "Would you like to join our staff?" And so I had never thought about being a sports medicine doctor. I really thought I was just going to do adult reconstructive, but an opportunity like that, you didn't want to pass up. And so I said, yes, I'd love to. And so I got there and I was absolutely clueless on how to take care of these players. I mean, they'd complain about something. I had no idea what it was, why they had it, how significant it was, how long it was going to take them to get better. And it was a nightmare. I needed a lot of hand holding. I think that's all the kind of stuff you learn in fellowship, or if you hadn't had a fellowship, on the job training, it's very difficult. And so fortunately, my partner, it was Joe Chandler, who was the team physician, was very helpful, kind of guided me through a lot of stuff. And I read as much as I could, and just studied the players and that sort of thing. And it literally took me about 10 years before I really felt confident with it. But each year I felt better about it, and I started giving talks on it, and I realized how I didn't know anything about it, and sort of refined my understanding of it over many years. But I remember one story when it was after a game, and I'm sitting in the training room with one of the relief pitchers, and I'm sitting there, and the head trainer's there, and the general manager is there, and Bobby Cox is there. And so I'm examining the player, and they're looking at me, and they go, well, and so I start pontificating on, well, I think he's got this, I think we got to do that, and da 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 da, and we'll try this, and blah blah blah. And they're all looking at me. I mean, literally, they're looking at me like bird dogs looking at a downed duck or something, and there's silence. They're just looking at me, and I'm looking at them like I'm not saying something that they want to hear. And finally the trainer says to me, well, can he play? And I said, oh yeah, he can play. And they go, oh, and then everybody stood up and walked out of the room. That's all they want to know, whether he can play or not. Everything else they could care less about. And it was just sort of that understanding, that mentality of the players and of the coaches, and the fact that this is a business, and they have to field the team. So it was fascinating. I loved it because I learned so much about the pathophysiology of throwing, and of how these injuries occur, and how you treat them, and how they're important, and things like that. So I loved my experience with the Braves. I mean, it's very time consuming and hard work, because it's such a long season, so many games involved. But it really opened a lot of doors for me too, because once you sort of start learning about it, start teaching about it, everybody wants to learn, how do you take care of these players? And they place such unique stresses on their bodies that unless you really take care of baseball players, you don't understand the significance of some injuries. And the same with the physical therapists and trainers. Unless you have a physical therapist who deals with baseball players, I'm sure it's true of a lot of sports, they don't understand the significance of certain injuries, and don't know how to deal with it exactly. So it was wonderful. It was really very fortunate. Of course, the vagaries of sport, they brought in a new management team because the team wasn't doing well, and they fired everybody and all that kind of stuff. And so, sort of an ignominious ending to the whole thing. But, they say that it after about 10 years, you're trying to look for a way to get out of it anyway, because it's so much work and you're not getting that much out of it anymore. But I did it for did it for 19 years, and I was the head team physician for the last 9 years of it. So it was a really, really, really good experience. I think it helped my career a lot, helped my understanding of the shoulder a lot. And yeah, I think if you have an opportunity to deal with a team like that, it's just such a interesting thing to do, just for the learning aspects of it, that it really is great.
Certainly, I take care of some baseball players in my practice, not probably as many as you do, but they're a very challenging patient population. And I totally agree with you that I think that you can understand the shoulder, and not if you don't understand that sport, it makes it challenging. I mean, certainly, for instance, your paper on posterior labral repairs in throwers, I think, is a real landmark paper. I've heard people say, oh, you should treat all those injuries non-operatively. And I often point to that paper to say, you can be successful if there's a structural pathology. And I know other surgeons have been swayed towards operative treatment. Tell us about that.
Yeah, it's interesting. It's sort of scary, because you're taking care of these patients and you don't have a lot of options. And and you see this pathology and you don't have a lot of guidance in terms of how to proceed with it. And you have to sort of go with your gut. And, you start to learn things like when patients say that, my shoulder pain comes on after ball release. That's like a alarm signal that's posterior labrum. So usually it's like if they have pain with late cocking, early acceleration, you're thinking cuff. But if they say pain after ball release, you have to ask them, because they say it hurts when I throw, and then you have to say, well, when do you feel it? Right when you let go of the ball, and they go, yeah, that's posterior labrum. So you get in there and you think, okay, what should I do here? And so obviously, the major leaguers, you really worry because you can't experiment. But with the minor leaguers, you figure that you got to do something to help this guy maintain his career. And so we just developed the philosophy that we say, look, we're going to fix whatever's torn. And if we see a frank tear, we're going to fix it, and we'll fix that area, and we'll try not to, Jimmy Andrews always said, do the least amount you can in that shoulder. And I think that's a good philosophy with these throwers. And so we started to do it, and started getting some good success out of it, and kept doing it. And then just, then looked up our results. And, obviously that was a much small group out of a much larger group in which we were doing that surgery. Part of it too is figuring out how to operate on the posterior labrum, because years ago, we all felt very comfortable doing a Bankart repair, but nobody felt really comfortable. Like, how do you get that anchor back there at that 7 o'clock position posteriorly, And so I came up with the idea of just turning my body around. And if I was doing a left shoulder, I'd mentally tell myself I'm doing a Bankart on a right shoulder when I'd really be doing a posterior labrum on a left shoulder. And then turn the screen around so it's behind the patient. And so you're looking this right direction, and you just kind of mentally told yourself you were, doing the same thing as a Bankart repair, just on the opposite side of the shoulder. And so that trick worked. You kind of played around with portals to figure out how do you get there safely, and I think some of this you have to follow your gut. I was always worried about, that lower portal to go across the axillary nerve. And so we used the high portal, and it worked fine. We started out trying to use the Wilmington portal, I didn't find that satisfactory. So, but it was kind of just moved it a little bit, and it worked out fine for the posterior labrum. And so the whole thing is an evolution, and I think in your practice, what you need to do is identify the things that you don't understand or aren't working for you. And even if you can't figure them out right away, keep them in the back of your mind, because at some point something's going to happen where it's going to trigger in you, like, oh, I bet this is true, or I bet I can do this, or I could do that instead of what I'm doing right now. And so, it kind of evolves, and you've got to look your results up, because you got to make sure that it's working, because often you don't get a good gestalt unless you do that. And so that was a very satisfying study we did, on the posterior labrum, because the results were so good in that patient group. And kind of the rubber hit the road with Brian McCann, who was, our catcher, he's all-star catcher, and he batted left-handed and threw right-handed, and he tore his labrum halfway through that year. And so halfway through a year, and from like July on, he was miserable the rest of the season. He couldn't bat because when he swung, he had pain, but he could throw fine. And so then we worked him up, and he had a posterior labral tear, and then so he's trying to figure out what to do about it. And so I searched the literature. There's only that one paper that Steve Burkhart was on, that I can't remember who the lead was on it, but it had 12 patients, and I think there were 5 different authors that came up with the 12 patients, but they had good results. I think Josh Dines was on that as well. He might have been the lead. And so I said to Brian, I go, look, the results seem to be good with this type of problem. I think we should try and operate, because we tried to rehab him for 3 or 4 months, and he was doing horribly, and it was coming into a contract year the next year. And so he went and got an opinion from Jimmy Andrews, got an opinion from Neil Elatrash, and then we actually all met at one of the academy meetings and talked about him. And Jimmy joked, he goes, right now he can throw, but he can't hit. If you fix him, he might be able to hit, and he won't be able to throw. And so, you're damned if you do, damned if you don't. And so, the agents typically dictate who's going to do the surgery in the end, but I had a good relationship with Brian. And so he let me do the surgery. And at that point, I had enough confidence, that we'd done it on other people that it would work. And he did fantastically well, and he went on, had a great year the next year, and then signed a $84 million contract with the Yankees after that, and just, finished his career with the Astros and won a World Series. And he's moved back to Atlanta, and he's a great guy. But that's like one of those high profile, like, you're either going to shine or you're going to go down in flames. And that's the thing about these pro sports guys, it's high profile, so high risk, high reward. But it was kind of an evolution, learning, the whole process of learning how to take care of these and not knowing. So the road's not there in front of you. You have to create the road. And I think that happens in a lot of people's careers, and in all areas, not just sports. And I think you just have to constantly be looking for what makes sense, and then evaluate to make sure that what you're doing actually is working.
Well, it's a wonderful story. I mean, it's certainly, I'm sure, looking back, a fond memory of a time you took a chance and it really worked. Another one of your papers that I often cite in conversation is your partial repair study. And what I think is interesting about the study is you have pretty good results. And when you use it as a comparison to many of the procedures that have been invented since your paper, and I think the paper was published in 2006. So since then, we've got superior capsular reconstruction, lower PCS transfer. I mean, these things they didn't even exist then. And I think, now that we have all these new shiny toys, we've kind of forgotten about the partial repair because everything that's new and shiny is exciting. So, I mean, you see trends come and go in massive cuff tears. I'm sure you look back on that paper, and even the paper you write, this should be used as a comparison for new procedures or tendon transfers or augmentation. I mean, tell us your perspective on that procedure, kind of from the vantage point we have now.
Yeah, it's interesting because, we all know that there are people out there with asymptomatic rotator cuff tears, and it's all about having a balanced repair, and this is, Steve Burkhart was the person that really figured all this out and talked about the suspension bridge model. And he wrote that first paper on that, and again, they had very few patients in that. And I had this resident at Emory who was bugging me for a research project, and I was pretty young in my career still. And so I said, all right, well, why don't you just look up all my massive rotator cuff tears, and then we can do something on that. So we pulled all the lists, and so he kind of went through everything, and he came back to me and said, you have more partial repairs than are listed in the literature. And I said, really? And and because, Louis Bigliani's philosophy on these was fix everything. He and Rockwood would butt heads because Rockwood would be out there saying, look, just to breathe the patients, they'll do okay. And Louis was, no, you can fix these. And so I would fix them, everything I could fix. And then if I had a gap, I'd leave it. And I'd figure, well, they'll probably be able to get enough balance, healing here that they'll do okay. And then you sort of feel like, well, I think I'm doing what everybody else is doing. And the resident told me, he goes, no, nobody else is doing this but you. And I thought, well, that's interesting. And so we looked all those patients up, and the results were, they were decent, and you start to realize that it's all about the pattern of the tear, and all the stuff that Burkhart talked about. So if you could get, a subscap, a teres, and half of an infra, very often he had a good shoulder. And so, some patients just did remarkably well and other ones didn't. And so, you wonder, it's just like, any other treatment. You say, well, if this is your baseline, where I think we had like, half of the patients, or maybe slightly under half, had excellent results. And, then you have to take that into account when you're looking at the balloon, or you're looking at the different kind of tendon transfers and that sort of thing, because often it's just your basic underlying residual cuff that's doing that and nothing else. So I think people have to be very, wary of that, and just to understand that even these other techniques, the balloon is predicated on rehabilitating the shoulder to the point where you can reestablish that balance, force couples. So it's the same idea. It's just a facilitation of that. And then if you look at the the superior capsular reconstruction, and a lot of those cases, people are doing a partial repair and that, and so you wonder how much is coming from each of those elements of the repair, and it does give you pause. Certainly I've seen patients who you couldn't do a partial repair on, the classic 50-year-old with a large super infra tear, and they just got teres and subscap left, and so there is a place for the tendon transfers. I never had good luck with the latissimus transfer. It was hit or miss, but I think this lower trap transfer is actually something that's going to be very helpful. The way we do our superior capsular reconstructions, I'm not sure is the best, just because that tissue is just not that strong like what the Japanese use. And lately I've been trying to incorporate the biceps as much as I can into my repairs, and we'll see how that works out. But it is interesting, how you kind of evolve with your technique, and you sort of think, well, I'm doing it the same way I was taught, and then you realize you just gradually deviated based on your own concepts of what you think makes sense and what doesn't.
Let's switch over a little bit to the ASES, and we would love to hear from you about your favorite memories of ASES meetings over the year, perhaps your top memory. And of course, with this past year, with your involvement with the ASES, your presidency, tell us a little bit about what the society has meant to you and what you think your legacy is within the society.
Well, that's a lot of questions there, Rachel. My so probably the memory I have the best of, it was my first ASES meeting. When I came in 2001, and it was back in the day, the 200 people in the entire organization, and everybody in that room had a textbook with their name on it or published all the main literature. And I just felt like a kid in a candy shop. It's just so thrilled to be there. And that meeting was in Pebble Beach, which was a beautiful place to have a meeting to start with. And just everything about that meeting, and just sitting around the bonfires talking to all these people, and everybody was so friendly and nice, and sort of like you'd gotten into the club. And it was just a wonderful, wonderful experience. And it's the kind of thing that really motivates you to kind of keep moving forward with your career, and do research, and really teach, and kind of keep pushing the ball forward. um, the ASES has evolved, and I think it's a good evolution to a bigger organization, for everyone that's interested in shoulder, because we were losing very talented people to sports medicine and arthroscopy just because they couldn't get into shoulder and elbow. And so, great minds were focusing on other areas. And so I think it was very wise that we did what we did. Um, this past year has been a great year. I think it's funny, Anna Quintanilla, who's our executive administrator, said to me at one point, she goes, I think we need a rule that every 5th year we need a private practice guy to run the organization. Because in private practice, you're used to paying attention to the finances and the organization and the committees and all that kind of stuff. Whereas the academic guys are more focused on the teaching and then everything else. But, you need both of those to make an organization run. I think, probably my biggest legacy is what I've been able to do with the traveling fellowships. So I came on the presidential line like 3 years ago. And just as I came on, the Brazilians had requested to send traveling fellows to the United States. And the ASES had said, I'm sorry, we can't accommodate them. And so that happened just as I came on. And I said, that's not right. I mean, the Brazilians are some of the most important, people internationally in the shoulder world, and we need to be able to accommodate them. So I said, do you guys mind if I take that on as my presidential project, is to see if I can sort out what's going on with our fellowships? And they said, have at it. They were happy to have me take that on. And so I must have called about 20 people, around, the past presidents and people, in charge of the committee, and they were all pulling their hair out thinking, this is such a mess, and we've been trying to fix it. It can't be fixed. And I kind of finally sorted through everything. And of course, one of the people that had the most information was Evan Flato, who had been president several years before. And so between him and Jeff Abrams, I found out there was actually money in the foundation designated towards the traveling fellowships, and that a commitment had been made by ASES to fund all of the CSEC ASES, reciprocating traveling fellowships, because now each country is sort of paying for the other country, each group was. And so, and this whole thing had sort of evolved in a hodgepodge fashion where the Chinese had requested to come over and we said yes. The Japanese had requested to come over and we said yes in unilateral fashion. And then the Koreans had something unofficial through Hawkins. And then when Hawkins retired, Hawkins asked the ASES, would they assume, that traveling fellowship? And we said yes. And so, so all these things kind of hodgepodge together. And so I worked with Ed McFarland, who runs that committee. He's a great guy and very devoted to it. And we sort of figured, okay, we have money, and then we sort of started working through our budget, and then we figured out, you know what? Not only do we have money, we have enough money where we could expand this program. And so we said, well, how should we expand it? So we wrote a letter to all the international shoulder and elbow organizations around the world and said, we're thinking about, upgrading our program and expanding it. And what would you like to see? And by and large, we heard from most everybody to say, we would like you to send more American fellows to our country, and so we thought, okay, well, what makes sense? And we thought an Asian fellowship would make a lot of sense. But we were trying to make sure that it wasn't just one of those countries. So we had to get Korea, Japan, and China to agree to do one together, which took a while. But they all agreed to do that. And then, we got it orchestrated. We got funding for it. And we just sent our two first fellows there this year, Stephanie Mu and Louis Shi went, and they had a fantastic time. And I think it was a great, it was a great experience for both the Asian countries who sponsored them, and then for us, and certainly for the two of them. They just had a fantastic time. So since that time, I have also gone back to the Latin Americans, and there's a political minefield down there just because there's so many different countries, a lot of competition and rivalries, and we have organized that. So there's going to be unilateral Latin American fellows coming next year. And then at our meeting, we talked to the Australians, and again, they're a group that has a little bit of a chip on their shoulder. They sort of feel like they have as much to teach as they have to learn, which is true. A lot of these countries do, but they're eager to start doing it now too. I mean, it took some little cajoling there, but so I really think that the traveling fellowships are a transformative experience for the fellows that do them. It creates a bond between mid-career academic surgeons that will lead to increasing collaboration, increasing exchange of ideas, and increase the closeness between our different societies. So I just think it opens so many doors, and I know Dr. Neer was always super keen on traveling on foreign fellows. So he typically had one American fellow and one international fellow. And so, because he was very committed to international teaching. And I believe that. I think it's very important for us to do it because the exchange of ideas is so critical that, no matter where you are, the giants in your country will sort of dominate the thought. And so, but when a giant from another country comes and says something very different that works, then you have to reevaluate your whole concept of how things work and what the best treatment is for certain problems. It really expands your universe to do that. So I think that more than anything else. I mean, I've done some other stuff, like our finances were a mess just because we just separated from the academy, and we had basically three siloed organizations, the society, the, the foundation, and the journal. And so, I had fixed finances in another large organization before, so I knew how to do that. So I got a financial team in, and we've done that, but that's sort of just, business things. But it's been a fantastic year. I mean, we have so many talented and eager members like you guys, that are doing things like this that really go above and beyond. That it's really just a matter of getting everybody lined up in the right direction.
Well, it's the fellowship thing in particular is a huge contribution. I mean, I speaking as someone who's tried to travel internationally to learn from other surgeons, it's been an incredibly eye-opening experience. And I think what you just mentioned is accurate. I mean, it's incredibly valuable. There's one question we've asked to a lot of the science of shoulder and elbow surgery that have come onto our podcast. We want to ask you, and it's, if you could have dinner with any person in history, who would it be and where would you have dinner?
Is this like a shoulder surgeon or anybody?
Any person.
Any person. Wow, hadn't really thought about that. I think you'd have to think of some of the greats, like either Galileo or Leonardo da Vinci, somebody like that, because their minds were so expansive. I mean, they just thought about so many different things at once, and I think that they were people like we are in certain ways that are kind of moving forward, and the path is uncertain, and you're trying to figure your way forward and make sense of the universe, and we're trying to make sense of the shoulder and how we take care of patients and things like that. And if the path is not always clear, so it requires some imagination, some creativity, and I think somebody like that who has so much creativity and just how they think and how they approach the world, it would be very fascinating. Where would I go? I think I'd eat at some nice Basque restaurant in northern Spain, because that's my heritage. My grandfather was a chef in a Basque restaurant, so I enjoy that food.
I wonder what Galileo would order for dinner at a Basque restaurant.
Sardines, I think.
Sardines. I'm just picturing you and Galileo sitting down to dinner, a dinner of sardines in northern Spain.
Yeah, it could happen.
It sounds great. You should do it. Yeah, I wish it could happen. Yeah.
Well, we want to thank you so much for coming on and spending, close to an hour with us. And I know both Pete and I could chat with you for forever, and I'm sure our listeners would enjoy more time with you. But we want to be respectful of you and your evening. So we really want to thank you for coming on to this podcast and spending so much time with us.
Well, it's my pleasure. It's really been great, and I really appreciate all that you guys do for American Shoulder and Elbow. And this whole podcast, I think future leaders self-identify, and you guys certainly shown a lot of leadership in doing this and taking on this project. And I think it's another benefit for our members, and it's really interesting to hear all the different stories. So thank you for including me.
Well, thank you. And thanks for contributing to those stories. Again, this was up there with one of the top podcasts I think that we've done in the history of the ASES podcast. So thank you so much. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.